Hello, everyone. I am Ricardo Cohen, the current president of IFSO Global. And today, on the World Obesity Day, I'm very happy and honored to present this webinar along with two very estimate colleagues and friends, uh, Professor Luis Barr and Professor Peter Schwartz, who I'll introduce later. I want to remind you that we have the chat just on below on the bottom of your screen. You can ask questions and the faculty will gladly respond to them. And this webinar is being recorded and will be available in the YouTube channel, the IFSO YouTube channel, and in the IFSO Virtual Academy that is hosted in our IFSO website. So feel free to ask questions to this very skilled faculty. Professor Louise Barr, she's professor of pediatrics at the University of Sydney and the immediate past president of the World Obesity Federation. Professor Peter Schwartz, our panelist, he is the current president of IDF, the International Diabetes Federation, and he's the head of the Department of Prevention and Care of Diabetes at the University of Dresden. With no further ado, I'm going to start with my presentation on what the Lancet Commission on the new definitions of obesity may change the landscape of treating obesity. And just afterwards, Professor Barr will speak about environmental changes that can reframe obesity care. So I'm going to share my screen and start my presentation. Those are my disclosures related to this presentation. I think the one who's most related is that I'm a commissioner, as Dr. Barr is, of the Lancet Commission on the Definition of Clinical Obesity. The question that comes, is obesity a disease? May be very pedestrian to this audience. However, I believe, and all the Lancet Commission believes, that the current definition of obesity does not adequately address the issue of obesity as a disease because the idea is very controversial. There are people who defend and claim that, yes, obesity is a chronic, relapsing, and eventually progressive disease, while others, look at your bottom of your screen, claim that obesity is not a disease, that obesity may be a lifestyle, a risk factor that can be changed by lifestyle. So what was the problem that we sought to address within the Lancet Commission? Because we have evidences that obesity is not approached as a disease state. First, there is inadequate use of prevention strategies instead of treatment. Second, we have a clear inadequate access and use of evidence-based therapy, either clinical, pharmacological, or surgical. There's a huge misconception of the reversibility of obesity, no matter how severe is the disease. There's a big tolerance for quackery, miraculous diets, miraculous compound drugs that comes with magic behind it. We had a huge widespread of bias and stigma against obesity and against its treatment. So that's the problem. The idea of obesity as a modifiable risk factor, that lifestyle changes can modify the evolution of obesity. The Lancet Commission represented all corners of the world with academic clinicians, scientists, public health specialists, patients representatives, and World Health Organization officers. If you look here at the commissioners, you're going to recognize very high-ranked people in the obesity field that were part of this commission. And we understand that obesity is a spectrum. Look at your left side of the screen, there's Maria. Maria has a BMI of 37 without any symptoms. In her medical assessment, she has normal heart, lung, and kidney function. She has no diabetes. She may have a slight elevated cholesterol, a slight risk factor, but in her daily activities, she's an active teacher, a mother of three, and she enjoys running. She does 10 kilometers in 1 hour. So she's pretty fit with her BMI of 37. We have Jack on the right side of your screen, where he has a BMI of 39, fatigue, dyspnea, and on minimal exertion. He has lower limbs edema. In his medical assessment, he had some pulmonary and heart dysfunctions. He has severe sleep apnea on CPAP, no diabetes. in his daily life activities, he's currently unemployed because he lacks mobility and he regrets not being able to play soccer with his son anymore. Uh, because the current definition of obesity is that a condition of excess adiposity that may pose risk to health. We don't know exactly. First, when you have a condition of excess adiposity, you judge and make a diagnosis, quotes, through corpulence to a physical phenotype. And when we say that it may pose a risk to health, we actually do not measure the health impact of the disease, obesity. So this is not the Commission's definition. It comes from a dictionary. A disease has an adverse effect on health at the present. So it has certain signs and symptoms and or limitations of daily activities. We have here a gentleman walking on the street. There's a hole ahead of him and or her. All of a sudden, we have a, a, a sign, danger. So this, when this gentleman or this lady reads the the sign, he'll say, well, there's a hole there, danger. I'll look carefully and avoid falling down. However, if he or her already has fallen down, I don't need that sign anymore. I need to rescue him or her because I have a problem. I need to fix it. That's the same of risk and disease, risk and illness in obesity. Like an umbrella definition is not helpful at all because remember the sign. If I have a patient with a risk, I can use prophylactic care aiming risk reduction. However, if I have an illness, so the person is already has fallen into the hole, I need to rescue him. So I need to treat a disease with a therapeutic intent. So a broad definition is not helpful at all. And we see today less than 1 or 2% have access to metabolic bariatric surgery, and less than 10% has access to medications. So we're doing something wrong. We don't have a diagnosis of obesity. We have today a classification of obesity. We say obesity class 1, class 2, class 3, because those numbers based on BMI, they do not risk of health consequences. However, it does not measure fat directly. It not establish the distribution of fat around the body, and it cannot determine if there's a health problem because of this adipose tissue accumulation. This is the classical anatomy of a disease. We have etiologies, pathophysiologies, and an illness that has signs and symptoms. It expresses an organ dysfunction. It has a characteristic cluster, has a typical evolution in time, and it has signs and symptoms at the present moment. It's not only a risk factor. Diabetes, it's a disease by its own right. It has an etiology of several different etiologies, pathophysiology, and clinical manifestations, fatigue, polyuria, polydipsia, polyphagia, weight loss or weight gain. And it has complications, micro and macrovascular. So diabetes by itself has an identity of an illness as a standalone disease. And the current framing of obesity, besides being a diagnosis by corpulence, which is very stigmatizing. We have mechanism of adipose tissue expansion, a physical phenotype, again, corpulence, discrimination, and bias. We have pathophysiological mechanisms. However, we always think in the old way that we have obesity-related diseases like diabetes, cancer, who are exactly diseases in their own right and not signs and symptoms of an illness. So that was the crucial missing piece that the Lancet Commission addressed. What are the clinical manifestations of obesity as a standalone disease? Well, the principles that we use for identifying the diagnostic criteria, well, first, they should follow a clinical rationale frequently occurring in obesity. They would be clearly linked to the pathophysiology of obesity, like metabolic, hormonal, inflammatory. So there's a pathophysiological rationale. And the health impact rationale, if those signs and symptoms contributed to the impact of obesity on the physical and or mental health of the individual. So those were the principles. And then we came out with criteria for diagnosis of clinical obesity in adults and children. I won't go through the 18 for adults and the 13 for children, but they are there. So we went to the signs and symptoms that correlate directly to the complications of obesity. The question that arises always is, can we still use BMI to assess a person with obesity? Yes, we can. However, that's the start. Look at your left side of your screen. We should have at least one measurement of body size and BMI, like waist circumference, waist to hip ratio, waist to height ratio, BMI plus one of them, or two of the anthropometric measures without the need of a BMI. So at least two measurements of body size regardless of BMI, or when available, direct body fat measurements such as DEXA, MRI, etc. The Lancet Commission assumed that excess body fat can pragmatically be assumed if BMI is over 40 kilograms per square meter. So we came with a new diagnostic framework that reflects exactly the nuanced significance of obesity in an individual. So preclinical obesity is a condition where we have obesity, excess body fat associated with a different and variable level of health risk, but without an ongoing illness. So it's like Maria. She has no evidence of reduced organ or tissue dysfunction. She runs 10Ks, remember, she can complete a day-to-day activities, and those people, they are generally at a high risk of developing diseases such as the evolution to clinical obesity, cardiovascular disease, some cancers, and type 2 diabetes. And we have clinical obesity, remember Jack. So it's a chronic disease due to obesity alone, characterized by signs and symptoms of an ongoing, at the present, organ dysfunction or a reduced ability to go for their daily activities. So Jack had, for example, may have breathlessness caused by the effects of obesity on his heart and lungs, joint pains, a cluster of some metabolic abnormalities like low HDL, high triglyceride, and high glycemia, and dysfunction of other organs, including kidneys, upper airways, and reproductive system. What was the rationale of the preclinical obesity thing based on other diseases that really exists in medicine? So a pre-disease refers to conditions that are not classified as diseases, but they do not indicate a disease-free status. Example, an HIV infection, if not carefully monitored and treated, may progress to AIDS. Colonic polyps may make an evolution to colon cancer, pre-diabetes to diabetes, osteopenia to osteoporosis. The scope for preclinical obesity is aimed to risk reduction with preventing prophylactic intent. Public health policies should be evidence-based and stigma-free. And at the individual level, in people with low risk, screening and monitoring over time, and in people with high risk, they may require therapeutic interventions, either medical or treatment. An example, if we have a person with preclinical obesity and type 2 diabetes, two different diseases, and we know that weight loss is a very powerful alternative to put diabetes into remission, yes, we're going to treat high risk patients with preclinical obesity because they have diabetes as another disease. And we know that treating preclinical obesity will put diabetes into remission. So it's not an exclusion of non-treating preclinical obesity. We treat people at an individual level according to their risk to their health. The scope of care in clinical obesity, we have therapeutic intents, and we aim for remission of clinical manifestations of obesity. Finally, we can have a measure obesity with signs and symptoms, and if we put them into the signs and symptoms into remission, we can say, yes, we can have clinical obesity into remission. That doesn't mean cure, as we need to treat patients for life. The other treatment options are lifestyle plus pharmacological, surgical, or the combination of both, because what we want is a timely access to evidence-based treatments, prioritizing those who need the most. The scope of care, if we compare risk factors to diseases, look at the prioritization and the acceptance of risk of any treatment. So when we have a defined illness with its own identity, we prioritize who are sicker. And second, we accept we are more open to accept risks of any treatment in patients with an illness, with a disease. A big example in the surgical area is when a surgeon performs a total gastrectomy with a Roux-en-Y reconstruction for a gastric cancer, and this patient has a leak, of course unwanted, but he has a leak. The patient, the family, and all the society will say, well, it's an accepted complication because he was treated from a cancer. However, if the same surgeon performs a Roux-en-Y gastric bypass for clinical obesity and the patient has a leak, probably all people will look at him and say, well, obesity is a modified risk factor. Why operate that patient? So the acceptance of the complications is lower than on a patient treated with the same operation for cancer. The Lancet Commission offer a meaningful and ethical alternative to help optimizing the allocations of limited resources to prevent and treat obesity. What do I mean by this? If I have patients with preclinical obesity in the spectrum of evolution from preclinical to clinical obesity, I can use different strategies to take care of people with preclinical obesity, preventive and prophylactic in most of patients with low risk to their health, while in clinical obesity, we can allocate resources to those who need most. A good example of this, we have an island with some snakes, poisonous snakes, and we have people who live on regular houses and others who live on top of trees. So we have people who are more at risk of being bitten by the poisonous snake. So if they're bitten, they should be prioritized for treatment, while those who live in the top of the trees where the snakes cannot reach them easily, those are taken care with preventive measures to avoid to be bitten by a snake. This is a good example of what we mean by preventive strategies versus prioritization to those who need most, who were bitten by a poisonous snake, but they should have prioritization to care. And finally, we can redefine the treatment outcomes in obesity. If we have symptoms, we can put them into remission, and we can tell the patient that yes, he or she is into remission, and we need to follow him up for life because the therapeutic intent was achieve success. Today, obesity defined as currently is a problem for payers, for policymakers, and for public health professionals. So we want, with a new definition of clinical obesity, offer an evidence-based way to screen those patients who have allocated limited resources to people most in need. This is the All of Us data, very interesting data, according from Eric Rasmussen from Pennington Biomedical Institute. Look at the number here in red. It's 240,000 patients that had all their electronic health records complete. And among those 240,000 patients, we have patients with obesity classified by BMI around 42%, while those with abdominal obesity measured by waist to height ratio 58%. It's a huge number. Then, when they used the Lancet-based clinical prevalence, confirmed obesity went down to 31%, and those who should need prioritization because they have clinical obesity, it's 20%. So we help public health authorities, policymakers, and payers to prioritize those patients who are most in need of treatment. So this is very interesting. We went from almost 50% to 20%. And if you look at those old patients, the old classification of patients with overweight, we can see here that they have at least two anthropometric measures that define excess adiposity, plus 11% of those could be prioritized for treatment because they already have an organ dysfunction, regardless of BMI. So this is a clear example how the definition of clinical and preclinical obesity can help everybody. It's a win-win-win situation with prioritization, allocation of resources, and benefits for patients vary according to their clinical status. I'm a marathon runner, so I'm stubborn and I like to make a lot of effort. And my effort today is to increase access to all obesity treatment. And how the Lancet Commission can help us. This is a definition that is fighting against corpulence, fighting against the diagnosis of obesity by a size of a person. And we know that weight stigma delayed access to any treatment, surgical or clinical or medical. So first, we shift focus from body size to measure health impairments. Second, we can ensure equitable treatment access regardless of corpulence. We should train all healthcare providers to eliminate weight bias in their clinical decision making, recognizing obesity as a medical condition, not a personal failing. Plus, clinical obesity is a standalone illness. So, as I showed in the All of Us study, this may reshape healthcare policies. We don't need other disease to treat clinical obesity. For example, semaglutide was available in some countries regardless of obesity if a patient had diabetes. However, if that patient had a clinical obesity with signs and symptoms, access to the drug was denied because he or she had no diabetes. This is very, very stigmatizing. And finally, we can have insurance approvals and public or private based on organ dysfunctions rather on BMI alone, and early intervention as a disease modifying treatment either in preclinical or clinical obesity. The Lancet Commission on Clinical Obesity, what can this change in our clinical practice? Decreasing obesity and its treatments and stigmatization, as I showed, prioritization of treatment, not based on BMI, but or the need of other diseases to grant access to treatments. Finally, we can measure and report remission of clinical obesity through their signs and symptoms. And we can inform policymakers and public and private payers about how and how much they can or they should allocate resources to treat patients in need. So I think this will lead more demand for all treatment options. I hope these presentations make you excited to read our 42 pages long paper. It's a long one, but I can guarantee you is a very nice experience and very educating one. Thank you very much for your attention. Luis, I think we can fill the questions and discuss later after your presentation.
Yeah, Ricardo, in the moment there are no questions yet. Let me comment for 1 second. I must say I'm extremely thankful for the activities of the Lancet Commission, especially with the term pre-obesity, because as you mentioned, that pre-diabetes and diabetes is a kind of conversation or continuum of disease development. This is what we also see with the obesity. It's not a certain erratic point where you say this person is sick and the other one not. It's a continuum. And we like to use often the example of blood pressure treatment, where we say, okay, if you have an elevation in blood pressure, we know it will lead to hypertension, it will lead to myocardial infarction or stroke. And our concept is to treat this as early as possible. And from the diabetes point of view, we always say, why waiting until the person has type 2 diabetes? Why not acting earlier? And this is what is now possible with the new recommendation of the Lancet Commission. So a big thank you very much for this work. And it will change the opportunities for many people with pre-obesity and obesity to get access to treatment.
Great. Yeah, that was one of our big purposes of the Lancet Commission, is to define a new framework to measure the health impact of preclinical and clinical obesity, thus having different strategies. So thank you very much for your comments, Peter. Thank you very much. Louise, are you ready?
Yes, my talk has been pre-recorded.
Yeah.
Good morning, good afternoon, and good evening. I'm here as past president of the World Obesity Federation, and I'm going to be speaking particularly about issues to do with prevention and environmental change. But I also come to you as a paediatrician working with children and young people with severe obesity in terms of their clinical care. Now, obesity is often seen as an individual issue, but as we all know, the reality is far more complex. Failing systems, health systems, food systems, regulatory systems, government, and even urban design are actually driving rates of obesity worldwide. And people respond physiologically and keep on responding physiologically to these systems, to this broader environment. A genetic predisposition for an individual can thus be turned into the lived reality of obesity because of the world in which they and we all live. Now, many factors combine to drive the increased obesity rates globally. And here we see the roots that we've had here for world obesity in terms of thinking about both biological and genetic risk, but also food changes, food environments, the access or not to healthcare, the life events we've experienced, our exposure to different types of marketing, including food marketing, our mental health, our sleep patterns, the stigma we've experienced, all influence the development or not of obesity. And you can therefore appreciate that no single intervention can halt the rise of the growing obesity epidemic. Rather, addressing obesity requires a comprehensive approach across food and health systems, multiple environments, and in the wider society. We all need to work together to change these systems, so health systems that are ill-equipped to care for people with obesity, or health and broader social systems that perpetuate bias and stigma towards people living with obesity. Food systems where multinational corporations produce unhealthy food and then spend billions of dollars surrounding people with a whole array of marketing, including advertisements. And the planning and physical and transport systems that discourage active travel and being physically active. So we know that walkable neighbourhoods make physical activity the easy or default choice. I put choice in inverted commas here because it is a choice if you have the option to go into those areas. It is a choice if you've got walkable neighbourhoods, if there are playgrounds for children to play, safe pedestrian crossings, if you can go shopping easily as a pedestrian. But this is often not the case. This is in stark contrast to many cities and increasing numbers of neighbourhoods that promote car use and keep people indoors, that make it very difficult to be a pedestrian. So which type of physical activity environment would support clinical care recommendations to walk more often and increase physical activity? I think it's quite clear. What about affordable and accessible healthy food options and clear food labelling to support healthy food choices? Again, the inverted commas. There are a whole array of strategies that can be done to support these. However, they need to are often up against ubiquitous food marketing, which makes healthy choices much more difficult. Yes, for children, yes, for young people, but also for older adults. And the examples I've chosen here are actually on public transport, in schools, and in hospitals. It's almost impossible to escape them. So again, which food environments would support clinical care recommendations to eat well and follow agreed dietary plans? There's no question, is there? Addressing environmental change will, in effect, support provision of good clinical care for people living with obesity. I want to highlight that it's not a choice between addressing obesogenic environments or addressing health systems. It's both. Addressing prevention or treatment management, it's both. Addressing lifestyle behaviour change or addressing healthcare interventions, it's both. Fairly recently, the 75th World Health Assembly adopted a new set of recommendations for the prevention and management of obesity throughout the life course. There was an accompanying acceleration plan to support implementation in selected front-runner countries in every WHO region. It was recognised that action was needed across multiple systems that drive and influence obesity. And for many of the vast majority of front-runner countries, they wanted to address issues like standards, legislation and regulations, obesity management, including health service delivery, sugar-sweetened beverage taxes, food marketing, early food environments, physical activity environments, front of pack labelling, and school nutrition policies. So quite an array of environments and settings and systems that needed to be addressed. The WHO Acceleration Plan, with the acronym ACT, ACT, so they're attaining, enabling and supportive environments, catalysing impact of structural and system changes, that's essentially public education, and transforming the health system, that's the health sector. All of these systems, early food environments, school environments, active environments, broader public education, health sector, need to be addressed. Essentially, to transform the failing systems that drive obesity, and in order to build a healthier future, we need collective action. This is at governmental level. It needs to be whole of government approach. So it's not just the health ministry. It's transport, it's agriculture, it's schools, it's social services, it's an enormous number of finance systems and so on. We need to involve health professionals across all specialties and working at all levels of the health system. We need to engage civil society advocates, researchers, wider professions, and really importantly, the public, everyone across all countries. We do need to change systems in order to support healthier lives. I encourage you to look at more information on the World Obesity Day website and also the World Obesity Federation website. And I thank you.
Thank you very much, Louise. Very interesting presentation that should raise the attention for all people, healthcare professionals who live around the world, to change our minds. We need to act, otherwise we won't win this battle. We have two questions here before we discuss among us. One is from a good friend, Jaime Ponce. He's a bariatric surgeon from the US. And his question is, what is the recommendation to match the new IFSO ASMBS guidelines with the Lancet Commission, specifically in patients with BMI 35 to 40? Actually, Jaime, I will answer with a reverse relation. I think that our guidelines should adapt today in patients with BMIs 30 to 40 with the new reality. So if we have persons with clinical obesity in any range of BMI, they should be prioritized to treatment. So I think in our guidelines, IFSO ASMBS, we should, in a very near future, to address this, like not having the surgical indication based on BMIs, but rather based on the health impact of clinical obesity. That's the same thing happens in the labels of the GLP-1 receptor analogs and the dual agonists, tirzepatide and semaglutide. They just remove BMI from their labels. So I don't know if they were waiting for our definitions or not. However, they changed that in November 2024, where the medication should be prescribed to those individuals with health impacts from their obesity. So I think we should adapt to that. And the other question comes from Mark Miller. How do you think the report will change how primary care physicians approach obesity? Any practical tips/advice in everyday practice? Louise, would you like to address this one?
Yes, we've been reflecting a little bit. I think this comes to the issue of how we support, what resources are made available to support a range of clinicians to be able to more easily assess the health impacts of high BMI or high body fat in the patients that they see. Of course, just to remind people, the report was only published in January, so it's not surprising that we don't have a vast array of dissemination strategies already worked out. But that is certainly an issue, for example, in Australia, because we've had people say, I'm a GP, I'm working in this setting, what resources can we use to actually better assess people? And I actually think that's a reasonable question. I think people say, how do I do this better in a very efficient way? So, sorry, yeah, that's just a bit of saying, I think we need to do work to develop easy to use assessment tools. The actual Lancet report does have, for example, a checklist that people can use, but I think most people in primary care want something that's very streamlined to their health system as well. I think it will make it easier for family doctors, people in primary care to be able to more easily delve into health issues. I think we go away from a straight BMI focus to actually thinking about health consequences. There are people who have a high BMI who don't have a high body fat. We think of elite athletes, particularly rugby players. That's an Australia, New Zealand, UK analogy. But also there are people with a high body fat, the Marias of the world, who don't have significant health issues. And I think we need to get away from just classifying people because of their BMI, but instead to actually focus upon what health impacts this person has. And I think means that we start to talk about issues to do with heart problems or breathing. It means that we start to do a broader systems review, take a medical history as well as a family history to get a sense of risk. That's a very long-winded way of saying that we're going to do things a little bit differently, but we will need some implementation resources. And I think that's something for every single country. Medical professionals, health professionals in various, in their different countries can actually help develop resources that can be used for simple assessment, easy assessment of patients.
Great, thank you. Peter, there's a question here from William Johari. I'm William, a family physician and diabetes educator from Indonesia. We know that Asia Pacific have a lower BMI cutoff in diagnosing obesity. My question is, what about the waist to hip ratio or weight to height ratio? Is there a specific cutoff for them? Would you like to address this, Peter?
Yeah, what we see in Asia Pacific, Southeast Asia, is that the phenotype, and I'm thinking from the diabetes perspective, is very different to the phenotype we see here in Europe or North America or also Australia. The colleagues in India, for example, always tell me the patients are slim, fat patients getting diabetes. And if you have this in mind, the average person getting diabetes in India is 28 years old, is female, and has a BMI of 24. And this is an example that the classifying the obesity based on the BMI, at least in Southeast Asia, has strong limitations. And from our diabetes perspective, what is important for us is not to see the fat mass on the human, to differentiate between the different fat compartments, so subcutaneous fat, visceral fat, and especially liver fat. So the liver fat is much more predominant for the development of diabetes and associated diseases. Why I'm saying this? Because this at the end says that waist-hip ratio or waist-height ratio must be different in Southeast Asian population. And there's a lot of research ongoing. Is any of the two calculations the right one to define risk, or what is the right approach in India, Southeast Asia for these people? Because at the end, if we wait too long, think about the example, 28 years old female getting diabetes because of obesity or because of the accumulation of liver fat by eating too many fried carbs in India. If we wait too long, it significantly increases morbidity and mortality for this patient. So I'm strongly voting that we start as early as possible, as intensive as possible. As Louise already has mentioned, the environment, targeted intervention, but also building healthy opportunities like avoiding to eat fried carbs, or avoiding at least to eat fried products, which already would have an impact in the generation of obesity and the development of diabetes. So there's no clear recommendation yet what kind of calculation is the perfect one for South Asian population. at least the BMI is not the right one.
Luis?
Yes, I'd like to comment upon this as well. I work in Sydney in Australia, which is a very multicultural city in a multicultural country, and I have lots of patients, and there's a large population from South Asia, Southeast Asia, and also the Western Pacific. So, and that's my clinical practice. So I completely agree that people from South Asian and Southeast Asian background are at higher risk at a lower BMI of type 2 diabetes and related issues. And it's one of the reasons that in those countries they tend to have what they have been doing at a population level is using a lower BMI cut points. As I understand, the waist to height ratio, certainly that we use in children and young people, we use the same sort of cut point to denote risk, 0.5 in that sense. And I think it's reasonably, it's not specific to individual, to different ethnic groups. So that's part of the assessment. In the Lancet Commission, we said, yes, high BMI is important, but we didn't actually say what that BMI cut point was, I'll just highlight, plus some measure of fat distribution. So we suggested waist to height ratio, waist to hip ratio, and we did say, and if you've got access to more sophisticated body composition tools, such as DEXA, then that's a really good way to get a sense of that. But we did not require that because this is something that's got to be used in low resource settings. So it was done with the concept that it could be used in a range of countries, especially the Asian region. If you look at the one of the appendices in the Lancet Commission, there's actually a section on BMI cut points and waist to height ratio and things such as that, specifically with a viewpoint of people from different ethnicities. And that was developed by the people from the Asia Pacific region. I might add too that in my clinical practice, or in my in my city of Sydney, where we have a lot of people from the Pacific and Maori backgrounds, you can have a higher BMI before type 2 diabetes risk sets in as well. So it's not just people of lower BMI, but also some who can carry a higher BMI without having that intra-abdominal fat or and other issues. So we just need to realise that we don't just have one BMI. We're not saying ditch BMI. We're saying BMI plus a whole range of other strategies. BMI plus fat distribution plus medical history are part of what we're using now to define clinical obesity.
No, that's ditch BMI as the only way to classify obesity. This is what we did with the Lancet Commission. It's not ditching completely, but it's not a major player. So this is what it could conclude.
I see it as a useful initial screening tool because it's available for everybody, but then it's got to be supplemented by a measure of fat distribution, most usefully things like waist to height ratio and so on. But the most important thing is taking a medical history and, if needed, doing investigations to work out if someone's got fatty liver, heart problems, high blood pressure.
The metabolic cluster, etc.
Yes.
Yeah. Luis, there's a question that two questions that I think you can address both. One is from Manisha Sharma, the other from Georgina Garcia. They congratulate for the presentations, and Manisha sees a lot of patients with adverse childhood events and associate unresolved emotional traumas as a cause of obesity, which must be addressed as a primordial prevention. What's your view on that? And then Georgina compliments, she's a pediatrician in Mexico. And what can you tell us about habit modifications in patients for adherence to healthy living strategies? So you could merge both answers.
Okay, well, first of all, you're quite right. Adverse childhood experiences are now recognised to be part of be a risk for actually perhaps triggering or putting someone at much higher risk, both in childhood, but also particularly through to adulthood of the later development of obesity, presumably through a number of pathways that are stress related. And so it's hugely important, whatever happens, for someone who's had, and adverse childhood experiences will include things such as experience of poverty, domestic violence, being a refugee, a whole, experiencing, a whole lot of awful events, put kids at the risk of a whole lot of health problems, including obesity and later obesity. Whatever happens, I think that needs to be addressed. And indeed, so no matter what the BMI, the support needs to be given to people who've had that experience. In treating someone who's got a high BMI, I think you can't just take a very straight approach to saying food in, food out. Like, that just isn't going to work. You need to look at the whole person. And if there are significant psychological issues, or if someone is living in poverty or dealing with inordinate, difficult psychological, social problems, they must be addressed, and sometimes may need to be addressed to a large extent before effective obesity treatment can occur. And that's the case whether you're an adult or a young person. Now, I've just forgotten those other questions. So the other question was about, I can't quite remember the wording, and
yes, Georgina is a pediatrician in Mexico. What can you tell us about habit modifications in patients for adherence to healthy living strategies?
Okay, well, that's a simple question. Sorry. Look, one of the nice things about being a pediatrician is that interacting with children and young people, that there's always, you've always got the support of a family, often extended family there to engage them. We certainly, with children, younger children, we always really engage. Parents are seen as the agents of change, and it's they that we need to engage in treatment. When you're dealing with an adolescent, that you increasingly have autonomy for the young person, but they still need the support, the framework of the family to help them. So it's always that complexity in pediatrics, that you've got to deal with the family as well as the young person. That's part of the joy of pediatrics as well. It's a lot of the same principles that we know of: frequent, regular support, and a lot of very sorry, I'm not answering the best way we can. We do know from a range of studies that probably lifestyle behavioural interventions have better long-term outcomes when undertaken in children with obesity than in, for example, adults with obesity. And you can understand why, because there's less established habits. However, it's really important to address those and to provide the support. You can't just say to people, do this. You need to actually give support, and that's frequent, regular therapist support. And we would, in the city where I live, we can actually refer families also to some primary care group programs or other things that are available, that are made available by a state government, that are relatively free or free for families. So we use things such as that. But it depends a little bit, well, it depends a great deal on the severity of obesity. If we're dealing with kids with severe obesity who've got health problems, then we'll actually take a far more assertive approach compared with someone who's just got mild obesity without a significant family history. Sorry, I can't go into huge detail, but I think you've got the general principles there.
I would like to comment on both questions, and start with the second one, with the why we often also fail with our interventions, or how we can increase adherence. Because we often believe that increasing the dosage of the intervention must get a better effect, because we know this from the pharmacotherapy. And we have a lot of experience in the diabetes sector, again, in Germany, with digital health interventions. And what we see is, if we are not able to address the need of the patients, the very intuitive need, and this might totally vary from the need we project to the patient, which is disease-related. If we are not able to address the need of the patient, we will fail with our intervention, at least in the digital field. And I think this is also relevant for all other interventions we are doing. If we increase the dosage again and again and again, but we fail to understand the need of the patient and are not addressing the need, then we might fail. But if we do so, I think this is a scalable way to increase adherence. And I also would like to comment the primordial aspect. Yannick et al. In India, they have done studies with women over 3 generations and assessed diabetes, obesity, many other morbidities. And it's fascinating to see that in the 3rd and 4th months of pregnancy, the amount of protein the mother is eating is directly related to the risk of getting diabetes. We don't know fully understand why, but we think it's the generation of the beta cells, and these people have less beta cells. And this is extremely relevant in an environment where most of the people are vegetarians. It doesn't matter where the protein is coming from, but those who had higher protein content, the babies lifelong had a much lower risk of getting obesity and diabetes. So the primordial aspect of prevention, I think, in the future becomes more important, more relevant, and it's not fully understood what the pregnant mother, how many good things the pregnant mother can do for her baby.
Thank you for raising these issues. I so agree with you. And I think you hit on a really good point about the idea of the health professional working in collaboration with the patient and, in my case, his or her family, to come up to support and to identify what the real health needs are, what the priorities are, and to take a more holistic view. I completely agree. And we can just keep reinforcing that. And you also highlighted the importance of the antenatal environment. And I'd say even before sperm meets ovum, the health of the mother and the father before that happens are also really important. And so this is part of the challenge, though, being able to do studies looking at those in more detail, but completely agree.
Oh, we're getting the last 5 minutes. There are 2 questions, probably quick answers. Peter, what's your thought about bioimpedance regarding the diagnosis of excess adiposity?
From the diabetes point of view, this is commonly used, and it's an easy way to measure full body fat, but it's not allowing to differentiate between full body fat, visceral fat, and liver fat. And from the diabetes point of view, visceral and liver fat is more important, but it's a commonly used screening method.
My other comment would be just be careful when using it in people with more severe obesity, because most of the validation work has been done in people with, more sort of nearer to normal weight distribution. So just be careful about the interpretation at extremes of body weight.
Great. And the final question before our final comments. There's a patient, a 32 years old lady, metabolically healthy. We don't really like this term, but it's okay. Glutafemoral obesity with a BMI of 34, irregular menstrual cycle, and problems with pregnancy due to increased estrogen formation in enlarged adipose tissue. This patient could be misdiagnosed as preclinical obesity, although she's quite a frequent case of clinical obesity. Yes, this lady looks like, without any other details on her clinical history and other blood tests to see if she fits in the cluster of the metabolic outcomes, that she may benefit a lot with obesity management medications for her treatment, as she has impairment of her ovulatory cycle. So yes, she would be a very good candidate for obesity management medication plus lifestyle intervention. I don't think there's any doubts on that.
Can I make a comment on
sure.
on the medication aspect, again, from the diabetes point of view? I think the drugs, especially GLP-1 agonists, the dual agonists, and in the future triple agonists, these are fascinating drugs, and they are very, very effective. The challenge, if we have the whole world in mind, is this is not an opportunity for most of the patients who pay for their medication in low and very low income countries. So we have to develop methods how using this GLP-1 analogs in combination with lifestyle interventions. So the concept that we use these good drugs to help the patient to lower weight and then find a way to sustain with the weight loss, because in most of the studies we see, if you stop the drug, then you gain weight again. And this, unfortunately, is commonly done in low and very low income countries. So this will in the future be a big challenge, how to get a good balance between price and effect and sustainability of the effect.
Great. Well, we have 2 minutes left. Please, Louise, your final thoughts on this World Obesity Day and the big battle that we face today with preclinical, clinical obesity, whatever we may call it. It's a pandemic. Please share your last thoughts.
Okay, high prevalence affecting people from around the world, high, low, and middle income countries. We need to take a systems approach. Yes, that includes the health system, and we've rightly focused on that here, but we need to think more broadly about changing systems and not blaming the individual, but thinking about broader environments. Thank you.
Peter?
I'm extremely happy about the term pre-obesity because this will give an access to intervention and medication for many people in the world. But we have to work on better accessibility and availability of the good interventions, the good medical interventions in low and very low income countries. And we have to focus on various measures of prevention of obesity to prevent comorbidities associated with it.
I second both messages. Actually, they're the same. And I thank the audience, and I thank you very much, Louise and Peter, to be with us. IFSO, it's not only a surgical federation, we are moving forward to a more comprehensive way to approach obesity. And again, thank you very much for your time and for your very valuable inputs. Very nice lecture, Louise. This may change the world in the near future. And again, thank you very much for being with us.
Thank you.